Hello, I'd like to welcome people as they arrive. This is the first symposium of Let's Talk Clots in celebration of World Thrombosis Day, which was Sunday the 13th of October. My name is Professor Beverley Hunt. I am Chair of the Trustees of Thrombosis UK. I just like to welcome so many people. So we've had an extraordinary response to our online conferences. We now have 2,783 people registered with us, of which nearly 2,500 are from the UK and the rest are from 59 different countries. This symposium will be going live now, and then it'll be available on the platform afterwards for those who can't attend now and would like to have a look at it. And I'd really like to thank our sponsors and supporters. And you can look at some free resources and find out more about network support by visiting the exhibition hall. And we'd love you to do that. That would encourage people to support us and bring in more funding for our future work. People are still arriving. I'm going to give a little bit longer. I have to apologize. I have a black eye. I'm not a victim of domestic violence. I went to give some lectures in Buenos Aires last week and I fell over on the cobblestones. And it's getting better. Thank you very much. Okay, so it's 2 minutes past 9, and we are going to start this session on organizing national problems with ongoing national problems with VTE prevention. We've got 3 speakers. We have Dr. Will Lester, who's going to speak first, and he's going to talk with the title of Translating Thrombosis Risk to Individualized Prevention. I think we all know Will in the thrombosis community very well. He's based in Birmingham. He's a consultant at the hospitals there and an honorary senior clinical lecturer in the Institute of Cardiovascular Sciences at the University of Birmingham. He's got lots of prizes, 2 of them for Thrombosis Innovation Awards for his work on thrombosis prevention. And being a member of the Hemostasis and Thrombosis Task Force for the British Society of Haematology Guidelines Committee. So I'm going to hand over to him. He has to go back to his clinic, so we will take questions just after his talk. Will, over to you. Thank you so much.
Thank you, Beverley. Hopefully you can see my slide.
Yeah.
Yeah, brilliant. Thanks. So just a few sort of declarations, and you'll see at the end why I put 5 NVIDIA shares on there. Just a bit of a warning, really, that sometimes I might say things that might be upsetting, perhaps considered heretical. So you've been warned. So what's the problem? So the problem is that admission to hospital is a major risk factor for VTE, and it should be at least partly preventable. We know that PE is the leading cause of maternal death in the UK. We know that cancer and its treatment has significant risk factors of VTE and will affect the cancer journey. And we also know that we need to predict the risk of recurrent VTE after the first event and balance that with a bleeding risk. So what are the considerations about how we manage these risks, and who do we intervene in terms of thromboprophylaxis, because that's the question. Do we give it to the very highest risk patients, all patients, or something in between? That is the question. I think we have to accept that most events occur in lower risk patients because there's more of them, but the risk to each individual in the lower risk group is very, very small. And therefore, if we give all low risk patients an intervention, a thromboprophylactic intervention that has a potential bleeding risk, there is a risk of net harm over benefit, and it makes it very, very costly. So various experts have looked at what they think is the risk of a VTE event that would justify thromboprophylaxis, and people have estimated that needs to be at least 1% for cost effectiveness for primary prophylaxis, and around the sort of 5% mark for secondary prophylaxis. That's prevention of a second event. And as well as cost, we have to think about, when we're designing a risk assessment tool, we have to think about the sort of carbon environmental risk as well, you know, with the sort of heparin industry using more CO2 than the automotive industry. So just to outline what I'm going to cover the hospital admission risk, obstetrics, cancer, and this is a spoiler alert, all of our current risk assessments are pretty terrible. We'll look briefly at assessing VTE recurrence and then suggestions for improvement. I think a lot of what I'll cover will get covered in more detail by the other speakers. First thing to bear in mind is that the risk of population and individual level are different, and this is something that's difficult to get your head around, but we nearly always use population risk and we apply it to the individual, and that is flawed. And I think the best way of explaining this in terms of why that's flawed is to look at the randomized controlled trial. So you take a group of people, some get placebo, some get the intervention, and you assume that everyone in the intervention group will get the same benefit and the same risk, but that's patently not true. And so some people in the treatment group will get excellent benefit, some people in the treatment group will get nothing, and some people will get harm. But the randomized controlled trial will not tell you about the heterogeneity in that treatment group. And therefore you apply population risk to an individual, but actually some will benefit more and some will benefit less. We underestimate and overestimate benefit and harm. And the problem with the randomized controlled trial is that it hasn't evolved over 70 years, unlike almost everything else in medicine. So what we need to understand is individual heterogeneity. So we need better ways, better studies to work out who's going to benefit from the intervention and who isn't. How can we do that? Well, people are looking at new styles of trials, these dynamic sort of trials where you essentially have a prognostic enrichment and stopping groups during the study itself, and you need an awful lot of computing power. Let's go back though to what we got now. So we have the nice NG89 statement that we should use for our patients admitted to hospital. And I'm sorry if this is very UK based talk. We should use a risk assessment tool, the commonest being the Department of Health tool. And lots of you will be familiar with this Department of Health tool. It's not really a sophisticated risk assessment tool. It is just a list of risks, and you tick any box, and then as long as there's not a contraindication, you give prophylaxis. And most patients admitted to hospital tick a box and therefore eligible for prophylaxis. So it's not really a sophisticated tool in any shape or form. But then we get an updated guidance from NICE saying, well, if you have identified a patient at risk, you really should be giving a minimum of 7 days to them. And most patients are in for maybe 2 or 3 days and go home. And therefore, to apply this to an enormous number of patients would be quite tricky. So there was an argument we put from the BSH to say that this was an inappropriate statement, that if you're in hospital for 7 days, that's fine, but you shouldn't apply this to patients going home after 2 or 3 days. The reason I brought this up is because of the response from NICE being very interesting, I think. And what they said is that it's acknowledged that the current risk assessment tool that we pretty much all university use may overprescribe prophylaxis without clear benefit, and suggested that perhaps we should consider using different risk assessment tools to the national tool. And that's why I brought this up. So what about Padua, which is a risk assessment tool? You need to, it's a scoring tool, so it's not just a tick box exercise. There's a sort of additive effect. And if you've got more than 4 score, you go for prophylaxis, and less than 4, not. And this is a bit of their data showing that high risk without prophylaxis, event-free survival is reduced. But if you give prophylaxis, you get something close to the low risk group if not needed anything. So yeah, it looks on the face of it pretty good. However, what would it do, I suppose, if we used Padua? So we actually looked at this in our trust, we did publish it, but what we did is we looked at those patients who had risk assessments done using the national tool, and we went back and then said, well, if we use Padua tool, would it make any difference? How many patients would we identify using the Padua versus the national? And there are lots of weaknesses of this, but essentially less than 50% of the patients who are identified to need thromboprophylaxis by the national tool would have needed by the Padua tool. So a lot less. And you might go, well, why don't we all change our risk assessment tool then? Is it because we follow the herd? Is it because we're risk averse? Are we worried about medical legal criticism? Is it just too much effort? The most important question to ask actually is there any evidence to support a superior risk assessment tool? And the answer is currently no. This is a nice study looking at basically multiple risk assessment tools. There are loads of them, and they looked at 24. And the conclusion is that no one tool clearly is better than another. And it's actually unclear whether any of them are better than just an unstructured clinical assessment. So unfortunately, the answer at the moment is we have no standout tool. They're all flawed, they're all designed based on retrospective data, and they all are weakly predictive. I'm going to touch on obstetrics briefly, and so is Beverley. What's the evidence base for an obstetric risk assessment tool, as on the one designed by the Royal College of Obs and Gynae Green Top guidelines? Well, it's all based on retrospective case studies. Very, very weak, very, very biased. There's only one randomized historical trial, actually, of low molecular weight in pregnancy, where 2 in the low molecular heparin arm got a clot and none in the placebo, however, clearly underpowered. Now, there are key risk factors that we're aware of in pregnancy. So what about BMI over 25? That's present in 78% of maternal deaths. And this is from the most recent Embrace report. And if you look at this graph here, what it shows you is that those who have obese class 3, that's a BMI over 40, it looks as if on the face of it, you've got a very high risk of thrombosis. But if you look at the axis, this is per 10,000 deliveries. So actually, this is 0.1% risk antenatally and just over 0.1 postnatally. So well below the 1% threshold that's thought to be cost effective for intervention. So we have to acknowledge that this is a common risk factor, but still an incredibly weak risk factor. And what RCOG have done is something slightly different than national tool, a bit more like Padua, although without any real evidence base. They've looked at cumulative risk, even though we don't understand how risks interact. So the recommendation is that you do a score and then you add up the score. And if you've got a score of 2 postnatally, you get the 10 days, more than 4 all the way through, 3 from 28 weeks to 6 weeks afterwards. We did a bit of a back of the envelope calculation actually based on our local data. And we found that over 5% of our pregnancy bookers had a risk score of 3 or more, based on what we would consider normal variables rather than disease state. So this is BMI, smoking parity, age. And with over 5% of pregnancies, if we applied that nationally, the cost of giving heparin based on this risk assessment tool was over £12 million per year. And it's obviously apparent that this risk assessment tool has not gone through a cost effectiveness assessment. And the question is, could we spend this £12 million more effectively? I think the answer is probably yes. And again, is there a standout risk assessment tool that we can use? And the answer, again, the same as with hospital admission, no, unfortunately. There are 19 risk assessment models were looked at in this study. Beverley is one of the authors. And again, none of them really pass the muster. And I think a very useful comment, we really need investigator-led research with decision analytical modeling. We need to do better. So Embrace, again, I know Beverley's going to touch on this. What they've recommended is restructuring the existing national VTE risk assessment tool to make it easier to use, clear and accurate. I think the last bit is the hardest bit because no one seems to have ever managed this before. And another thing about risk assessment tools is when do you apply them? Deaths are occurring in the first trimester and the risk assessment is traditionally done at booking after the first trimester. So if we're going to have an effective risk assessment tool, it needs to be applied at the right time. Briefly, cancer, just one slide. So this is thromboprophylaxis for ambulatory cancer patients. I know don't worry about the detail. This is from the BSH guidance, was published recently. There were loads of risk assessment tools that assess risk of ambulatory cancer patients, and they're all relatively complicated. They use biomarkers like P-select in some of them. And essentially, as far as I can tell, nobody has actually is actually using them. We're pretty good at giving prophylaxis to our myeloma patients. Hopefully, patients with metastatic pancreatic cancer are getting prophylaxis, although probably not in a lot of centres. But I think there's been voting with feet in terms of the risk assessment models that are used for cancer. And I think that's a real shame, but it just reflects the fact that our current risk assessment tools just aren't really passing the muster. What about predicting risk of VTE recurrence? This is my final thing. So when I see a patient in clinic who's had an unprovoked event, I want to talk to them about their potential risk of recurrence if they were to stop anticoagulation after their 3 to 6 months of treatment. And for example, for a male, one might say, well, your ballpark risk is 40% over the next 5 to 10 years if you stop anticoagulation now. However, again, this is flawed because we're applying the population risk to an individual. Some individuals will have 100% risk, some will have a 0% risk. So this is really a very flawed way of doing things, but it is very, very simple. So has anyone done any better? Well, this is the VTE Predict model, and I think it's interesting. You put in 13 patient variables. After you've done that, it will tell you what the potential risk of recurrence is for that individual versus their bleeding risk. So you can go on the website. It does give a warning saying this is not approved, so you can't use it for medical purposes. And you get this little thing to fill in with its 13 variables. And I fed in a fictitious 99-year-old who'd had an unprovoked event, PE. And it will tell you what the reduction is with treatment, the number needed to treat over 5 years versus the harm and the potential number needed to harm. So on the face of it, it looks pretty impressive and almost individualized. And there's even been a nice little study looking at whether it affects clinicians' behavior if you give them the stats from VTE Predict. And some clinicians did shorten their initial recommendation of duration based on the bleed risk that was identified in the tool. So on the face of it, all looks very good. However, I think we need to still look at the design of these risk assessment models. That again, they're based on retrospective analysis of trials and some population data. They are intrinsically at risk of bias, and they don't perform well using that methodology. So I'm going to mention C statistics now. I apologize, but the C statistics of this tool range from 0.48 to 0.71. And just to explain the C statistic, it's if you get someone with an event and then you pick another random patient out of a group, how good is the model at distinguishing that patient with the event versus one who didn't have an event? And a value of 0.5 means the model is no better than chance, like heads and tails. And really only models with values over 0.7 are good models. And you can see here, in terms of predicting recurrence, you're bordering on the random, better just to flip a coin. Maybe slightly better for bleeding, but really not encroaching on what is a good model. So even this model that looks good is not great. So in conclusion, we currently rely mainly on population risk, and we tend to apply this to individual patients, but that's intrinsically flawed. And this is because of the nature of the trials that we run, these RCTs. And unfortunately, we have no effective way of assessing individual risk using current RAM design. So our current VTE risk assessment tools are basically not fit for purpose. My personal opinion is, until we get better risk assessment tools, patient education about the symptoms and signs of VTE and staff and healthcare professional education are likely to be more important than risk assessment tools to prevent death versus giving pharmacological prophylaxis for risk groups. as most events can't be predicted, occur in the low risk group. And at least if you are aware of the symptoms and signs, then you will seek attention and get treated before it's fatal. So we need to up our game. We need to compare different risk assessment tools, I think, in prospective studies. And the reason for this is that we can't go back and use placebo because it's considered unethical. We need to compare different treatments, for example, low molecular weight versus aspirin in pregnancy. If we do these studies, we can get data which can be assessed, especially using modern computing power, that can give us more accurate ways of assessing individuals' risk. And I think we really do need AI to help sort this out.
Thank you, Will. Fantastic. So you've highlighted the ongoing issues that the VTE risk assessment tools aren't good enough, and we're pulling in too many people to get thromboprophylaxis. Do you want to discuss at all TripCast, which has?
Yeah, so I mean, TripCast
that's a major advance, I think.
Yeah, I mean, I didn't really have time to fit that in, but so TripCast is, you know, it's definitely going in the right direction in that they're properly sort of validating a score which appears on the face of it to identify the proper high risk population, and is far superior to what the GEMNet thing that we use at the moment, which is a very large net. So yeah, I think it's, I mean, say you may want to comment on it as well.
Yes, I think it's absolutely beautiful, because what it does, so this TripCast is identifying people at high risk of VTE with lower limb immobilization. You do have to go through about 20 factors, such as what type of immobilization and all the usual conventional ones, and it comes out with a score. And if you have a score less than 7, it says do not use thromboprophylaxis, and has actually validated that approach. So there were hardly any VTE events in the low risk group, and I do think it's a major step forward. And in the UK, we have got Tilly coming through, where we'll be looking in more detail of what type of thromboprophylaxis to use in the high risk ones. And that was such good talk. Well, there are some questions which are taking different approaches, and I'm going to read them out and you can decide what you want to answer. So there's anonymous attendee asking which risk assessment tool should be used for surgical termination of pregnancy, given surgery-related risk factors and early pregnancy risk factors.
I don't think we do have a good tool. You know, we need to basically consider we need to look at the patient's risk factors. In terms of the risk of the procedure itself, it's relatively low risk. The pregnancy itself in the background is a risk, and but it really has to be based on the patient's risk factors rather than necessarily the procedure. We don't even know how long to prophylax after a surgical termination. We say that the risk post delivery is 6 weeks. It's clearly not 6 weeks after a surgical termination early in the pregnancy. So the consensus that we came up with, certainly in the BSH HEMOBS group, was 1 week for prophylaxis for those individuals who are identified high risk. But as I say, the risk assessment tools are not great. I think we'd all accept that if someone's had a previous event, absolutely, that is a risk.
So yeah, so absolutely if they've had something before, but if they're slim and very active, we'd probably say no, but all between is very, very fuzzy. And I think if you pull back from that question is asking about a very specific circumstance. And what we're talking about is getting precision in VTE risk assessments. And maybe the person who asked that question needs to do the study in that group, please. That's a bit of a challenge. Okay, next question, long-term recurrent VTE management. How would you discuss benefits versus risks? Do you quote figures or only suggested benefits greater than risks?
Yeah, I mean, I use that marvelous slide that I showed, 40% for males, 30% for females, if you stop over the next 5 to 10 years. I use population risk because I'm not convinced that we do have a tool that is good enough, even VTE Predict, to give a proper individualized risk. I mean, I'm maybe a doubting Thomas, but unlike the TRIPS study that prospectively validated, they're all based on retrospective flawed, bias risked data basically. So I haven't gone over to VTE Predicts, but maybe other people have.
I don't think it's widely known, and I think you've been very helpful in advertising it here so people can take a look. It's terribly easy to use, and it gives you a rough idea of where you are more than anything else. But they did take VTE Predict out to I think it was 200 physicians who were managing patients, and they gave examples, and all the physicians gave different answers. And what VTE Predict did do was try and bring them together so they all gave similar answers. Okay, next question. Any evidence to use stockings in obstetrics? We seem to use it's a challenging area, and we've just had an email this morning from a hospital trying to stop various groups from using stockings, and the obstetricians are resisting. Any thoughts?
It's easy to answer that. No evidence. Pregnancy has been an evidence-free zone for anything until recently. Some studies are, I mean, maybe you'll talk about this yourself, but some studies are now being run. The stockings, absolutely not. I think we need to, well, we are going to try and give some guidance on this from the British Society of Haematology. And I think we use way too many stockings.
And we can sort of announce, do you want to announce the Stockings Off campaign?
Yeah, so it'll be part of the Stockings Off campaign, to produce a good practice paper from the BSH.
Okay. Then there's a question. In the interim, until a valid tool of assessment develops, what will be the best model to use at the moment?
Well, yeah, unfortunately, these two papers in BMJ Open that I touched on, there just isn't one. They're all flawed. So I can't recommend one. I mean, I think it would be good to go for a model that used less heparin, because it will pick up most high-risk patients. But yeah, you can't recommend any one single tool.
Okay. There's a few more. I'm going to do one more question. Could you please confirm place of stockings in day surgery patients, please?
Yeah, I think
you can emphasize.
Yeah, there's not enough data yet to convince NICE to say anything about stocks, but I think we can take a stab at it from BSH.
So there's the PET study going on at the moment, which is looking at prophylaxis with stockings in very low risk patients, mainly day cases, and we're randomizing 22,000 patients, and we're up to over 10. So we're hoping to finish off this year. So we'll have a evidence-based answer in a year, but in the interim, I would say don't use stockings. There's no evidence to support anywhere. So why would you use something where there's no evidence? It's such a waste of money. Now I'm going to stop now because Will has got to actually see some patients. Will, that was absolutely fabulous. It was a really good start to our symposium, and also to Let's Stop Clots. So thank you very much.
Thank you.
And have a great day.
Thank you.
Thank you. And I'm going to move on now, and we're very privileged to have with us Ethel Oldfield, who is going to talk to us about prevention of hospital-associated thrombosis in NHS England. Now, Ethel is currently head of patient safety and it's a branch called Oversights and Alerts for the NHS England National Patient Safety Team. She's a human factors specialist and a registered midwife. Today, she's going to share updates and insights on prevention or the prevention programme within NHS England. Ethel, thank you so much for coming, and really excited to hear what you've got to say. Thank you.
Thank you, Beverley. That's great. I'm going to attempt to share my screen. Hoping all goes well. So just give me one moment. Can you see my slides normally?
Yeah. Beautiful.
Excellent. Lovely, thank you. Thank you, everyone, and thank you very much for the invite to come and present to you today. So I'm Ethel Oldfield, one of the heads of patient safety at NHS England, and my role is quite varied, but I mainly work around the National Patient Safety Committee, which is where we get all the arm's length bodies together. So Department of Health, NICE, CQC, digital estates and facilities, and so on. So we try and get the national bodies to work together. So when we talk about looking at systems and safety, rather than just focusing on trusts and individuals, we need to look at the bigger system process. Obviously, this is a work in progress, so we may not change Rome in a day, but the reason I tell you about the Patient Safety Committee is because this is where this piece of work has come from. So as Beverley says, I'm a midwife by background, so I'm not here in a clinical perspective. My role is actually in the policy and strategy team in NHS England. So any clinical questions I will pass over to the experts. So I will just tell you a little bit today about some data that we've looked at and what we're trying to achieve, particularly in terms of the risk assessment data collection. I think what we can do is, if there are any questions, we will get back to you. And certainly from following on from Will, I think this is quite timely. So I'm going to show you a data slide. I've not got too many data slides. We have published a paper on this in the BMJ, so I'll share the link with you afterwards. This is predominantly NHS England. And from the National Patient Safety Committee, we did a review of the ONS and HES linked data. So that's the Office of National Statistics and I can't remember, hospital episodes. I can't remember what the S is for, but it's an accumulation of data joined together. The green line on top shows about 14,000 deaths a year, give or take, between 10 and 12,000 deaths a year. And with what we've put in there, so these are all the deaths where there's been a registered death with VTE on the death certificate. And you can see from the little arrows on there where things have happened over the years. So back from 2010, where the risk assessment and the sequence was mandated here in NHS England. And that is where trusts had to submit data every quarter and receive money in order to help them to manage that data collection process. So working our way through that green slide, that green line, you can see where the pandemic started and obviously it started to shoot up. The two bottom lines, and the very light grey one is the one that we were concerned about in particular. This is what we call hospital-acquired or healthcare-acquired VTE. This is where patients came into hospital with something not related to VTE, however had VTE on their death certificate. So we would call these healthcare or hospital-acquired. There's a little bit of debate around that, but we're quite concerned about those. So that's about 4,000 deaths a year. It's not changed massively over the time. So what we did in terms of NHS England, we looked at this as a group. I'm not going to go into all the details of this data. There's lots of raw data and it's been published, but just as a very brief overview, we looked at deaths from April 17 to March 2020. It was a retrospective cohort looking at death certificate and hospital activity data. Like I said, the main one was that we were concerned about is where there was no VTE diagnosis recorded as part of their admission, but they died from VTE. What we did find was there was quite a high number of inpatient and day case hospitalisation VTE deaths, and only 5% of the deaths followed planned inpatient admissions, so they were mainly emergency admissions. In terms of the emergency inpatient admissions, medical specialities and infection-related were primary diagnosis. So 86% of those deaths were people admitted as emergencies, and these were infections and so on. There's been a huge amount of work over the years for surgical patients, for elective surgery patients, and clearly that's made masses of difference. However, there's the bit around the medical patients, which is where we think there might be quite significant gaps. This data is quite raw, so it was a team within a couple of colleagues within the patient safety team that did this. The paper has been published by Francis Healy, and a number of us put together this paper, so it is on BMJ Open if you want to have a look, and goes into a lot more detail on this. But I think I'm speaking to the converted when we say VTE is not done. We're all here today to try and understand this better and try and make it better. In terms of what we did, so as the National Patient Safety Team, we took a paper to the NHS England Quality Improvement Committee, which is the senior kind of board, or was board at the time, back in 2022, I believe, and they were quite surprised at the figures of VTE. I think because of all the work that's been done over the years, people felt like, oh, VTE is done, it's fixed, it's not an issue anymore. Clearly, from the data that we found, very rough data, there is still quite a significant issue. So we took this to the National Patient Safety Committee, and this is where I got involved. Clearly, my background as a midwife in human factors. How did I end up in a policy lead for VTE? Who knows? Here we are. So we took it to the committee, and we asked all the members of the committee to review their work streams and see what were they doing in terms of VTE prevention. And we talked to CQC, NICE, the Association of Royal Colleges, Department of Health and Social Care, Digital, Health Education England as was. They're now part of NHS England. We spoke to the Healthcare Safety Investigation body and so on. We had lots of meetings with clinicians, with the exemplar sites, and we've probably spoken to some of you on this call today about this. We looked at education, we looked at Royal Colleges, and we also spoke to the Digital and Transformation team. We also looked at some of the research that's out there and ongoing at the minute. We talked and looked at what prevention was out there, particularly patient awareness. And this, I think, is a key area, and Will, you've touched on this, around patient awareness and how they can help themselves. And I think that's a huge area that we're probably not tapping into as much as we could. We also talked about the VTE risk assessment data collection, and I was quite pleased to hear Will talk about the risk assessments, that they're not effective. We don't know, how, this has come about. Here we are, we have to use them. And we did do a lot of discussion around the VTE data collection, which I'll explain for those of you who are not quite sure what this is at the minute. We also looked at the National Patient Safety Strategy and see if we could bring in some VTE prevention in terms of that. We're unable at this moment in time to have an improvement programme on VTE for various reasons. But we are trying to see, as a national team, what can we do to prevent this? In terms of the VTE risk assessment data collection, just a brief overview. This was started back in 2010. It was mandated that all trusts, so patients had to have risk assessments completed on them on admission to hospital. And as Will went through earlier on all the risk assessments, they are variable, and actually do they do any good? At the time, there was a secret attached to that, so funding was allocated to trusts to help them with that. From that funding, there was lots of VTE specialists, and the exemplar sites all came about from that, which was excellent. But like many things in healthcare, I think we start programs and we think we've got there, and then the money stops, and then trusts have to, manage their budgets and so on. So often these things just kind of fall off the wayside. The risk assessment data collection was paused at the start of the pandemic. We as a national team were not keen to reinstate this data collection because we felt it was a lot of time and effort and money to effectively tick a box. And this was the feeling we got from many of the people that we spoke to across the country, is that it's actually a tick box exercise. The risk assessment itself is so subjective. Does it actually make any difference? So we were not planning to reinstate this. However, there'd been requests from various places to reinstate this. As it had been stopped for a significant amount of time, in order to request a restart, it had to go through an data assurance process to see, is it effective? Is it good for money? Do the system want this? As part of that, we had to go out to all stakeholders. So it went out to all trusts to ask them about this, reinstating this. We did think, okay, if people want this, do we make this more meaningful, and do we add in some more metrics? So we had asked some questions around, do we add in questions like, okay, so has a risk assessment completed? If it has, is it correct? If anything was prescribed, was it prescribed? And if it was prescribed, was it given in a timely manner? However, the feedback and the cost of that was quite phenomenal, and it was not felt to be acceptable at that time, given the state the trusts are in and workloads and so on. So the data collection was reinstated as was from back in 2010. It started on the 1st of April this year, and the first data collection started in the first quarter, which was July. So we are just waiting for the first publication. Because it's been restarted, there's been a delay because the trusts are, for some reason, haven't had this message. We've sent it out in lots of ways, but also to the stakeholder groups. So we are awaiting the first collection of data to be published. We're expecting that to be a little bit hit and miss. It's going to take maybe a year or two for the kind of momentum to get going again, and for trusts to get back into that. It's not, there is no funding behind this. This is just something that, because it's been requested and the system wants it, it's happening. But we are very much of the opinion of Will that the risk assessments are not necessarily the right thing to do. But that is what the system is asking for at this moment in time. So what else can we do? And I think Will has touched on this, and I'm sure you all know this. We're speaking to the converted here. We need to understand it better. We still don't really know, more about the actual risk factors. Like, why do some people die? Why do some people don't? We need to look at more research. We need to look at drugs. We need to look at the dosage. Do we do risk assessments, or do we do universal thromboprophylaxis and risk assess the risk of bleeding? Would that reduce it? So we need research on that. I know there's been some risk assessments done on the universal thromboprophylaxis in terms of cost benefit, and actually it would be cheaper to do that. But in terms of safety, that's not yet been done. We also really need to look at VTE risks in medical patients and see can we mitigate these. Obviously, we need more data, but also a lot of these patients are now being managed on virtual wards. They've been managed out in the community, and we need to understand more. When patients do come to hospital, they're probably much sicker now than they were back 10, 20 years ago, because they've been managed at home a little bit longer. So they're already, not as mobile, probably not eating and drinking by the time they get there. There's also a huge public health message. I know post-COVID, the rates of obesity have increased enormously. Does that have an impact? And also patient awareness and staff awareness. So one of the other things I did, just kind of as part of this, to try and get just more general information around VTE, is we had a discussion with the patient safety specialists. So every trust in England has a patient safety specialist, and they focus on patient safety across their organisation. And we regularly meet with them monthly and present various different items and have lots of discussions. So I did ask a number of them around VTE in their organisation, and I asked very literally a few simple questions. So, do you have VTE as one of your priorities in your organisation's patient safety incident response plan? So this is part of PSARF, the Patient Safety Incident Response framework, which is changed from the SI framework. And as part of that, each trust has to develop an incident response plan. So how are they going to manage things? So of the specialists that responded, 35% of them said yes, they did have VTE in there, and 61% did not. 3% didn't know. One of the reasons we had this discussion with them was actually we need, if they've got a VTE specialist, which we'll talk about in a second, is do they link up together to look at safety and VTE, for example. We also asked, do they have a VTE specialist in their trust? And we were quite pleased that was 64% said yes, but not so great that 29% said no, but actually 6% didn't know. So we did suggest that they go away and within their organisation find out who the VTE specialist is and get them working together. I know people's jobs are full, and time is always really, really difficult. So hopefully just all these conversations are bringing people together. We're raising awareness of VTE and what we can do. We also asked them, what do you think we can do, or what can be done to reduce VTE across the system? And this is literally just a word cloud. And interestingly, patient information was one of the biggest kind of bits of feedback that we got, as well as PSARF. A lot talked about the risk assessment. There was a lot of talk about compliance. Given thromboprophylaxis was quite high on the list, but raising awareness, patient information, and PSARF. So bringing the looking at VTE as a whole as part of their PSARF or PSARP plan. So that was quite promising, I think, for us. But this is literally just the start, and it's starting this conversation. I guess my takeaway message is VTE is still an issue, and I know I'm speaking to the converted. There is lots already done, but we do have lots more to do, but we do need a lot more research. So if anybody would like to do some research studies, that would be really, really excellent. So that is all from me. Let me stop sharing my screen and get you back. Let's see if there's any questions.
Fantastic, Ethel. Thank you for updating us on really the NHS England view. I should say that Thrombosis UK was very anxious that we brought back VTE risk assessment, national collection of all the data, because we know since the pandemic that the eye has been off VTE, and when senior managers see we don't have to do anything nationally, less money is spent. So we know there are several hospitals who've lost their VTE prevention nurse because VTE prevention wasn't seen as an important issue. So I think that you will bring the focus back, and the patient safety people, I noticed they had leadership in 63% of the trust, but if you'd done it when we were all doing VTE collection of the data before COVID, it would have been nearly 100% because we've all got thromboprophylaxis committees. So I do think you're doing good by bringing it back. I really, really do. And we've got to keep it high on the healthcare agenda because these are preventable deaths and so easy to prevent if we do it properly. There are some questions in the chat now. Quite a lot are about the process. So could you just go through the process? You are wanting the submissions from the percentage of VTE risk assessment of all inpatients at 14 hours after admission. Is that true or not?
Yes. So whilst we're speaking, I will try and find the link and pop it in the chat as well, which gives some more of the information, which might be useful. And hopefully I'll remember this from my head. So there was lots of questions when we talked about reinstating this, and also previously, like prior to me being in this post pre-COVID, there was lots of questions around, there wasn't really a line in the sand. When are we measuring from? And it was a little bit vague. Whilst we don't want to make it difficult, without try and have some form of line in the sand, so we're all kind of singing from the same hymn sheet. NICE guidelines was a little bit unclear on that, but however, it did say if patient needs thromboprophylaxis, they should have it within 14 hours of admission. So, well, if you're given thromboprophylaxis, you will ideally have risk assessed prior to that. So that's why we put the 14-hour mark on that. We are in discussions with NICE to see if there's anything we can do with the guidelines, if there's any research that we can help with this, to try and back this up, just to make it clearer, because we do know it is a little bit vague, and also because there's been such changes in the system around what is an inpatient, and again, that's a little bit of a grey area as well, depending on where you work. So it's been a minefield for me, so I imagine it's a minefield for everybody else.
I think it is. We as a trust are doing 14 hours, but we know neighbouring trusts are doing 24 hours. So I think there needs to be a bit of publicity to say it actually is meant to be 14 hours. So we're not comparing apples with pears. And then someone says, please, when do we have to submit the second collection data VTE risk assessment?
So it's every quarter. April, May, June, July, September, October. So it's end of September, 1st of October. So it's normally open for a month. So I will try and pop the link in here, which is it's part of the national collection process. So in terms of dates, it's already set up. Sorry, I'm just trying to find. Here we go. And this has got a link to. So it's every quarter. If I pop it in the webinar chat.
Fantastic.
For everyone. So I'll pop the link in there, and it does have some information on there, which will hopefully help answer those questions. But it's quarterly data. It's the same as it was previously, no change. So no, you're welcome. Hope that's helpful.
Thank you. And there's a question here which I can help answer. Is there any work being done in understanding VTE in psychiatric patients, both inpatients and community?
So that is one of the areas there isn't. I mean, we spoke to various people when we were having these discussions, and it's very hard to find out what the deaths are, because the coding is different. So in terms of if a patient is in a psychiatric hospital and is admitted to ED, it's not necessarily picked up that they've come from another healthcare environment. So actually those 4,000 deaths could be higher because it's patients coming from psychiatric units. In terms of thromboprophylaxis, I think it's a little bit grey, certainly from the people that we've spoken to. They're like, yeah, I mean, it's not really a priority of ours. So that again needs a lot more work on that. We need to figure out some of the data. I know there's a colleague trying to look at some of the primary care and mental health data, but it's very, very early stages yet. We don't know is the honest answer. Unless you've got anything else.
Okay. Yes, so we've got a subcommittee in Thrombosis UK with psychiatrists, including Josie Jenkins, who in the past has done work in this area. And we are in the process of doing a systematic review of the antipsychotics because many of them are associated with increased VTE risk. Should they be in a special VTE risk assessment tool, which some of the psychiatric hospitals have made themselves? They're not validated. They've just said, well, if someone is in a catatonic state, they're not moving, they're going to need thromboprophylaxis. If they're on these antipsychotics and they're overweight, and well, they might need help. We've been working with the Irish VTE team, and there is a pharmacist there who's going to do a PhD in this area and try and get a really good tool working in Ireland, which I dare say we could borrow. And then lastly, we need the stats, just as you said. So Laura Roberts from King's and the Maudsley are working together to put in for a grant so that we can get some stats out about the rates of VTE in psychiatric patients. So I think we've got the vestiges of some data coming through in the next year.
Brilliant. Thank you.
Next, we've got a question. One problem is that juniors don't see much point in this risk assessment as it doesn't make a prediction nor give a weighted judgment. They are busy when on take and tend to overlook it, as it is often the case on post-take ward rounds. Do you have any comments on that? And
this was one of the reasons why we were not too keen on reinstating, because it doesn't particularly help. It does raise awareness, but it doesn't particularly help in terms of getting somebody having thromboprophylaxis. And a lot of the doctors that we spoke to, exactly as that said, you know, they often go on a ward round and they're handed like 28 sets of notes to do the risk assessment. Yeah, that's not quite how it should work. But again, that is something we need to look at in terms of education. I know the VTE network are looking at standards for VTE education across the system to have, you know, to try and standardize some of the education that goes out there. Human nature, yeah, we can't. It's human nature, and you know, trying to, you know, everything's a priority for clinicians. So it's really, really difficult.
Yes. And they have a lot of risk assessment and things to do, dementia scoring, all sorts of things when patients are admitted. So sometimes it gets forgotten. And there's this issue of having a hard stop. So many of the hospitals are now using the EPIC electronic system, and our VTE risk assessment is so bad that we are going to introduce a hard stop on our system, which I think it will be the first EPIC hard stop. It'll be interesting to see its impaction, because we can't get above 80% VTE risk assessment at this current time, and we obviously want to improve.
So when you say hard stop, do you mean so you can't like prescribe or give anything until the risk assessment is done? Is that what you mean by hard? Yeah.
Obviously, we're not going to do it in critical areas. You know, if someone's having a cardiac arrest and they can't get the right drugs given, that's obviously not correct. But for elective admissions, really we should be doing it, and then they have to do it there and then. And I think the other thing to say, you mentioned, should we give everybody thromboprophylaxis? A group of us with modelers did a big study looking at, should we do VTE risk assessment, or should we just give everybody thromboprophylaxis? And this is for medical inpatients. And actually, it's more cost effective just to prescribe everybody thromboprophylaxis, and then have some tool whereby you say, actually, this patient's got a bleeding risk, and cross it out. It reduces the amount of time people spend. And I think that we ought to explore that a lot more.
Yeah, and I think there's something there psychologically as well from a human factors perspective. If you're going to do something to somebody, it's more important than doing a very quick risk assessment and you say they're mobile, you don't need to move forward. So by actually doing something, there's a psychological process there which, is quite strong, I think. So, that would be really, really useful to look at the safety and efficacy of that as well.
Okay. And then there's a question, does the 14 hours start on A&E clocking or post-take? My answer to that would be from the date and time of admission. What's your answer to that, Ethel?
Of admission. I mean, we're not,
Yes.
so many people come into A&E. In an ideal world, you would risk assess them in A&E because they're there so long and they've been ill already, so they're probably already at a risk. However, we've got to be practical. You can't go out to an A&E waiting room and say, oh, you've been here all this time. It's from that point of admission where they're going to be admitted as an inpatient. So once that decision is made and they're waiting for a bed, that would be my take on that. But I think, again, that term of admission is a little bit grey in some places, which I know is very unhelpful. I can't say absolutely, because we work for some and not for others, and we want to make this as meaningful for each trust as possible.
Okay. And then the last question I got from John Stephen Shambangam. Is there any plan to look at VTE reassessments done after a patient has been admitted and their condition might have changed?
I mean, I believe that's part of the NICE guidelines in terms of us doing a national data collection. That's not something that's we're looking at the minute. I think there's a lot more we can do to try and find other ways to mitigate rather than just measuring risk assessments. And that may be something you can take up locally in your organisation to look at those. If you've got a VTE issue, it's not something we're planning to look at nationally.
Oh, and actually, I have to put this last question because this is a big one. When we first started VTE risk assessment, we cohorted out groups of patients, and one of them was day wards because they were only doing local anaesthetic and things like that. Whereas now, the average day ward might even do a mastectomy or a cholecystectomy. So the question here is, does admission include day case admissions, or only inpatients that stay at least overnight? We've changed our trust. We've said, right, day cases are now admissions, but we haven't got any national guidance. Sorry, Ethel, I interrupted you.
Yeah, so they are, and it is in the guidance, which is linked from that document, but I'll send you the actual guidance. Day case patients are classed as inpatients because, for that very reason, they are at significant risk. Even somebody who has, for example, I don't know, cataracts, maybe they're going to be at home and not very mobile for a couple of days. So it's thinking about those risks. There is so much more we need to do and understand. There we go. So there's the guidance. And just so when you scroll down the page, there's a bit where it says patients in scope of VTE. And if you click on that, there's a drop down. There's patients out of scope. And that's taken from the NICE guidelines. Because we're not there to make clinical decisions. That's where we get the NICE guidelines from. So they should include day case patients.
Wonderful. Well, thank you so much, Ethel. You've cleared up a lot of queries. So it's been so helpful having you. I'm hoping you'll come back in National Thrombosis Week and tell us how you're getting on. That would be really fantastic. That would be next May.
Lovely.
So thank you very much for today.
Thanks, Beverley, and thanks for the invitation. Any questions, just send them on if they're...
Oh, yes, we will. Thank you. Thanks for coming. Okay, so we're down to the last speaker, who happens to be me, so I don't have to introduce myself. You're saved from that. Let me just share my slides. Now, I hope you can see them. Jo, can you see them?
No, not yet.
No.
Oh, okay. Then let's try again. The usual messing around. Okay, window. There they are.
Just,
Now, how about that?
Yeah, I can see them.
Okay.
Perfect.
Okay. So I am going to talk about pregnancy in the puerperium and VTE prevention. And I had a lovely set of slides, which I have just dropped because we have a new Embrace report, and that shows that VTE is now the #1 cause of death in pregnancy in the puerperium in the UK. And I think we have to stop and look at their report and also look at their recommendations and really have a discussion afterwards. So this is fresh from Embrace. It came out this week. So I just would like it to help us think about the current issues around thromboprophylaxis. And if I have time, I will talk about what clinical trials would be most helpful now. So if we look at Embrace, and to remind you, in the United Kingdom, we are unique. We will do a post-mortem, usually a coroner's case, on every woman that dies in pregnancy in the puerperium. So we get a really good idea of what are the major problems in pregnancy. And this is the Embrace report. They do it over a 2-year period. So this is 2019 to 21. So this is the one before the one that came out this week. And when we look...
Sorry to interrupt.
Sorry?
It's just the slide hasn't moved on and it needs to go full screen.
Okay. Okay.
And just full screen. So I can see the maternal mortality by cause slide. Whether you can put it full screen.
I have put it full screen, but it's not moving. It's full screen now?
No.
Oh, okay. Let's go back. Can I do it like this?
Yes, you can do it like that. We're on learning objectives now. Thank you.
Yes. Okay. So this is going back to the previous Embrace report. It was in the time of COVID, and COVID was the #1 cause of death. But when we look and we go along the chart on the right, you'll see that with the hatched lines, that thrombosis is the #1 cause of direct maternal death, i.e., as a direct consequence of pregnancy, VTE is the #1 cause of death, and there were 33 deaths over that period. And this is the report that came out this week. They are really good on these infographics, and you can see here on the left we have the woman, and it says blood clots are responsible for 16% of the deaths, and that takes us up to 43 deaths. So the biggest cause by far. COVID has slipped back. Cardiac deaths follow, and then mental health conditions behind that. And I think as we walk through some of the cases, you'll see that mental health conditions will play an influence on VTE prevention. So if we look to the right, the key messages are to ensure women at high risk of VTE receive pre-pregnancy counselling and appropriately managed in the first trimester is one of the messages, and we'll see why in a minute. And they are also highly critical of the VTE risk assessment tool in pregnancy. Will showed it earlier. We're using the Royal College of Obstetricians risk assessment tool. It's quite complicated. The wording is sometimes a little bit obtuse, and they are calling for a better VTE risk assessment tool. And then the other thing that they point out and have a separate chapter on, this is 90 pages, by the way, is the fact that cancer will occur in some women. Of course, this is rare in pregnancy, and that some of the cancer patients died of thrombosis and received inadequate treatment, and they focus on that too. And then if we look on the right to figure 2.3, you can see maternal mortality by causes. And so we've got over 2 deaths per 100,000 pregnancies are due to thromboembolism. And when we look at the characteristics of the women who die from thromboembolism, you will note that the majority of them, 52%, between the ages of 25 and 34, but we have got a third over the age of 35. And of course, one of the characteristics of birth in the UK is that the average age of birth is climbing. And so we have a lot more older women, and we do have some women who are even in their 50s who are using donor eggs. If we move down, the other important thing I want you to think about is body mass index. So we are the fat man stroke woman of Europe, and our BMIs are climbing. I think the average BMI is about 28 in our population. And then when we look at the BMIs in the women that died from VTE, you will notice that the majority of them are overweight or obese. So we've got 40%, they've got a BMI greater than 25, and then over a third who've got a BMI over 30. Looking at ethnicity, we've got a lot of white Europeans, and we have most of those who died are non-smokers. So we've got increasing age as an important consideration. And remember, as you get older, your blood just gets more sticky, your fibrinogen rises, your other constituents change. And the other thing is our big problem, the obesity pandemic. So when we look at the deaths from VTE, according to trimester, the surprise is that we have quite a few who are dying in the first trimester. And then, as expected, we have got a considerable number who are dying postpartum. So when we look at that and we can compare that chart with the incidence of VTE in pregnancy, this is well-used graph, you'll see that the incidence is higher postpartum, so we're getting deaths there, but the incidence in the first trimester isn't as high, and we should just go back, you can see that we've got more deaths there. So we're not actually preventing deaths in the first trimester. And I don't know about you, but most of our women book at about 12 weeks. So they have been lost, and the deaths are occurring before they reach obstetric care. So when we have a look at the little vignettes, they tell us about various women, and these are so insightful. I thought it was worth just talking some of them through. So the first one is about vulnerable women. This is a woman with significant mental health problems, booked early and was assessed as high risk for VTE. Low molecular weight heparin was not prescribed. She was referred for smoking cessation and perinatal mental health services, but didn't attend either appointment. She was reviewed at 28 weeks gestation and prescribed low molecular weight heparin, but did not collect it from the pharmacy. There was little documented discussion about the importance or adherence to thromboprophylaxis. She gave birth and left hospital the same day. Low molecular weight heparin was dispensed after his discharge and not picked up. She was reviewed in the community and assessed for her mental health, but there were no inquiries about thromboprophylaxis. 3 weeks after giving birth, she collapsed at home and died from a pulmonary embolism. So difficult here. This is a woman who needed a lot more input and education about thromboprophylaxis and help in encouraging her to take her thromboprophylaxis. This second case is a woman in her late 20s in the first trimester of pregnancy and with no significant past medical history, presented to the emergency department early in the COVID pandemic. She had palpitations, shortness of breath, chest pain, and tachycardia. She didn't have a chest X-ray or any other imaging because she was pregnant, and a Wells score was used to assess her risk of VTE. So there's no contraindication to doing a chest X-ray in a pregnant woman, and the Wells score isn't validated for use in pregnancy. In fact, we know it doesn't work. She wasn't seen by an obstetrician or senior staff and was discharged with a diagnosis of possible upper respiratory viral infection. So the doctors weren't even thinking about VTE, which is a real problem if you're going to stay for the next symposium within medicine. Pulmonary embolism was not considered. A few days later, she was brought to the emergency department by ambulance and had a cardiac arrest on arrival. She was thrombolized and the CTPA showed bilateral pulmonary emboli. She was admitted to the intensive care but died shortly afterwards. So this is somebody who hasn't even reached obstetric care, and this is a failure to even consider the diagnosis in the emergency department with fatal consequences. The next one, an older woman with a history of VTE attended a consultation with her GP in very early pregnancy requesting thromboprophylaxis. The GP made repeated unsuccessful attempts to access an urgent obstetric review for the woman so she could commence thromboprophylaxis before ultimately referring her to the community midwife. She was unable to initiate thromboprophylaxis before she collapsed and died at home in the first trimester from pulmonary embolism. So this is a sign of our overstretched obstetric services. And also, I wonder why the GP didn't think to refer to the local hematologist as well to bypass this problem in obstetrics. Moving on, prescribing of thromboprophylaxis. So an older woman had 4 risk factors for VTE: age, parity, smoking, and raised BMI. She was prescribed low molecular weight heparin in the antenatal period and for 6 weeks postnatally. 3 weeks after giving birth, the woman collapsed and had a cardiac arrest at home. The post-mortem examination identified the cause of death as pulmonary embolism. The staff believed that because the woman had been prescribed thromboprophylaxis in previous pregnancies, she understood its importance and how to self-administer it. So I guess they hadn't reminded her. However, they learned that the woman did not take the thromboprophylaxis in either her current pregnancy or her previous pregnancies. They also learned that she didn't like the idea of injecting the medication into her abdomen whilst pregnant, and she wasn't aware that she could use other sites such as the leg for injection. This knowledge might have supported her to self-administer. So it's not enough communication between the teams and the patient. And this last case, a young woman with learning difficulties and mental health problems booked early in her second pregnancy. She attended the emergency department in her second trimester with chest pain and abnormal breathing and was prescribed a treatment dose of low molecular weight heparin. An outpatient diagnostic appointment was scheduled, but she didn't attend. The woman gave birth by planned cesarean section at term and was prescribed a 10-day course of postpartum thromboprophylaxis. 3 weeks after giving birth, she collapsed and died with a pulmonary embolism. And so the notes they make is in this hospital's pathway of care, pregnant women less than 28 weeks gestation who are diagnosed and treated for pulmonary embolism were required to inform maternity staff of the pulmonary embolism themselves, rather than the hospital notifying the obstetric team directly. So obviously the woman, because of her learning difficulties, didn't inform them about her diagnosis of a PE, and so the maternity staff weren't aware that she had had one. So this is just poor communication. So there is a a lot of soul searching in the Embrace report, and they come up with some new recommendations. So first, to clearly define the rapid access pathways for prescribing thromboprophylaxis to ensure that women known to be at risk are able to access thromboprophylaxis when they need it, particularly in the first trimester. And they have put that task to our integrated care boards and health boards. Now, I should say that this report is only written by obstetricians and obstetric physicians, and I think that there just aren't enough of them, and they're already overloaded, and they should have really brought in some obstetric hematologists to discuss this, because it would be really helpful if women that had a VTE in the past are told about their risk in pregnancy and have a fast pathway back to their clinic so they can start thromboprophylaxis as early as possible antenatally. Things like that, that really might help a lot, because we are short of midwives. So if we are going to include all these women and they have seen their midwives as soon as they're pregnant, how are we going to get that going? We'll need more midwives. We don't have them. Anyway, I hope we can discuss this in a minute. And then a very good point, to restructure the existing risk assessment tool based on research evidence. Well, they're going to have to look very hard. There isn't really much research evidence to say what is the best tool, and we actually need some basic studies to look at which are the most important risk factors. The Welsh are using a slightly reduced VTE risk assessment, which they showed was just as good as the Royal College of Obstetricians, and maybe they might consider that. So that's nice, talking to the Royal College of Obstetricians and Gynecologists. And then lastly, review ambulance service algorithms for risk categorization to ensure that 999 calls regarding women who are pregnant, recently pregnant, or have the potential to be pregnant are appropriately managed. And so ensure that repeated calls and calls made by minors are escalated to a rapid response by appropriately trained paramedics. So this is trying to get women who might have a PE into hospital more quickly, although I think probably better to try and prevent. And then they are asking for improvements in the guidelines. So develop a mechanism to ensure that all VTE risk assessment tools are consistent with national guidelines. Well, they are really already. It's just that they're not very good, and actually people have to use them and understand them. Women with previous VTE should be offered pre-pregnancy counselling and a prospective management plan for thromboprophylaxis and pregnancy made. Those who become pregnant before receiving such counselling should be referred at the earliest opportunity in pregnancy to a clinician with expertise in thrombosis and pregnancy. I would have said that really falls into the lap of the obstetric haematologists working with the obstetric physician. So it will affect the physicians on the call today who are doing obstetric haematology, or who have fertile women who've had previous VTE, and educating them and make it very clear to them that they can come to clinic, or they have an emergency phone number to phone if they are pregnant. Or even what we do is we give women who are fertile and considering pregnancy a supply of low molecular weight heparin, so that the day they have a positive pregnancy test, they can start taking it themselves, and they don't have to rush around and pick up supplies or engage with hospital staff. Antenatal thromboprophylaxis for those with previous VTE should begin in early in pregnancy as practical. Again, I would say this was something that would fall into the lap of the haematologists. If women need thromboprophylaxis as soon as they become pregnant, there should be a clear pathway for them to access prescriptions, which I've just mentioned. Risk assessment should be repeated. And then this damning statement: there is clear evidence that doctors and midwives find existing risk scoring systems difficult to apply in practice, and we need a new tool. And lastly, to keep repeating risk assessment. So that there's even more, which is too much, but this is all fine detail, which I haven't got time to talk about, but it's well worth looking at. You just type embrace in Google and this report will come up and you can download it. So when we sit back from this problem, we aren't alone. So in having high rates of death in pregnancy due to VTE, this is some work we did a couple of years ago looking at the United States. And in the States, the death rate due to VTE has fallen quite dramatically. And what we showed looking at maternal mortality was there was no fall in maternal mortality. And indeed, it was affecting the Hispanics and Black population more than others. So just looking and thinking about what is the evidence base for venous thromboembolism prevention in pregnancy? Well, really, there are no large trials. There's lots of little ones. And if we look at why that might be, it's because the science is quite hard. We are actually talking about a couple of deaths per 100,000. And if we want to do trials looking at whether this treatment or that treatment might be better, we'd need to enroll huge numbers of women, and it's just not possible to fund that type of study or to run it. It would be a lifetime's work. And the other issue is, if you talk to clinicians and patients, because we're so risk averse in pregnancy and we don't want to do any harm to the baby, we're much more likely to say, no, I don't want to go into this trial because I don't agree with this dose reduction or using a placebo. Probably no space now for placebo versus thromboprophylaxis. So we have poor guidelines, really, and the VTE risk assessment tools are very risk averse. If in doubt, you're giving thromboprophylaxis. So many women are getting it during pregnancy. About a third of our women get it in our obstetric unit. And then we have a bigger, wider problem, which is that the whole of the research environment is quite misogynistic. We have to remember that research funding groups have been for a long time, not so much now. The hunting grounds of white men, and there have been very few funding streams for pregnancy, even today. And there's such paternalism, especially in the States, in that many women are excluded from trials if they're pregnant because we don't want to do any harm to them, which is fine. But that means that we can't manage women in pregnancy because we don't have the data. And I do have a bit of a rant in this article that I published earlier in the year. And then we have had quite a lot today about stockings, and the evidence for anti-embolic stockings in pregnancy is there is nothing. Well, I tell a lie. There is one study which looked at flow rates in the leg in 5 women who were wearing stockings that came from Scotland. That's it, really. And we're extrapolating all the data from surgery, really. And this is a gap study, came out in COVID times, got forgotten a bit, where we randomized 2,000 patients who are moderate risk surgical patient to low molecular weight heparin and low molecular weight heparin and stockings. And then we looked at the VTE rates and we looked at silent DVT as well by doing an ultrasound. What did we find? No difference in rates of VTE. And as I mentioned earlier, we're looking at low risk patients with PET study, which is 22,000, and we're just starting GRACE, where we look at the use of stockings post discharge in 8,000 patients. So you're going to get the answers. But in the interim, why are we using stockings when there's no evidence? And lastly, I'll skip to the bottom of this. This is a very complex piece of work with Sarah Davis, who's a health economist. And we looked very, very hard using Bayes analysis about what would be the best place to start a trial in pregnancy. We used a new technique called this estimate of increase in net monetary benefit that could be achieved in different areas. And what we came out with, I haven't got time, is that the best place to start to do a proper trial in pregnancy would be in obese women after cesarean section or delivery, where we're giving them thromboprophylaxis, and there's so much uncertainty as whether we're doing any good at all. And it's acceptable to clinicians and patients. We discussed it with groups to actually look at that area. And I have had a call with NIHR, and I'm hoping that they will put out a funding call for this very soon. So what's next? Well, we need to await developments after the Embrace report. It's fairly explosive, and they have asked for action, which they don't normally do. I hope NIHR will commission a randomized controlled trial in obese postpartum women with thromboprophylaxis versus placebo. And we just need more data on PE in pregnancy. There are no guidelines on how to manage PE in pregnancy, and I'm really delighted to be working with HemeStar. We are hoping that we will get funding to go ahead and to do a prospective and retrospective audit of the management of PE in pregnancy. So I have come to an end, and I'd welcome some questions here. I'll stop sharing. There we go. And I can see there's some questions in the chat. I'm so sorry I'm sharing myself. Let's have a look. Adamantia Alatsica. What about D-dimers during pregnancy? I think it's not too expensive. So that's a bit of a loaded question. So if we look at the diagnosis of pulmonary embolism, we use the Wells score, and we would also use a D-dimer level outside of pregnancy. There have been some trials that suggest this is a possible way forward to go in the diagnosis of pulmonary embolism in pregnancy. And the European Cardiology Guidance on Managing PE in Pregnancy recommends it. But in the UK, we have decided not to follow this because we felt it wasn't safe. And that was because we had already done a study, and we had a big cohort of women where we knew they'd had a PE, and not all of them had raised D-dimers at the time of their PE. So for the moment in the UK, if you suspect PE in pregnancy, you do an ECG, a chest X-ray, and if you couldn't find anything else, you would go on to do imaging either with CTPA or VQ scan. All right, what about antiphospholipid antibodies during pregnancy? Do you think they can appear in some cases only during the pregnancy? Should we check them in women? So the answer is no. I don't think antiphospholipid antibodies are generated in pregnancy. They might happen because they were meant to happen anyway, but they aren't generated by pregnancy. And then, Bex Walsh, you've got it. It seems like the common theme is taking time with patients when assessing, when counselling, when considering individual risk. Do you think NHSE appreciate this? Well, we're going to make sure that they appreciate this, but it was a common theme of those women who died of PE that they didn't have enough time spent with them to persuade them that they needed to take thromboprophylaxis and show them how to do it. And we have had a group of women who've had VTE in pregnancy and discussed with them their views about thromboprophylaxis in pregnancy and taking heparin, and they were all saying they wanted more information from their individual medical team. So I think this is such a good point. We all ought to spend more time with our pregnant women. So I think I have come to the end. It's 10:30 and we have to call it to close. I'd like to thank you all for coming along. If you want to go and have a cup of coffee and come back again at 11, where we're going to talk about another issue which is very close to the heart of Thrombosis UK, which is diagnosing DVT, you'd be very welcome. It's just an hour. Thank you so much for attending. I hope you've learned something. I certainly have. Maybe see you later. Bye then.